Meningitis. Now, when you say meningitis, meningitis means it's inflammation of the meninges, like what I am telling you. Like let's say this is the brain, and then you have the covering here. Outside the brain, there is a covering of, first will be there pia mater, then there is the arachnoid mater, okay, and then the final covering is dura mater. So when you go from inside to outside, then you say ped. Pia mater, arachnoid mater, dura mater. So when there is the inflammation of the meninges, we are talking about the leptomeninges. Okay, leptomeninges. Leptomeninges means we are talking about pia mater and arachnoid mater. This pia mater and arachnoid mater, they are closely attached to each other, like a cobweb. Okay, so they are also called pia arachnoid sometimes, or they are called leptomeninges. So when there is inflammation of this leptomeningeal layer plus the subarachnoid space fluid, means CSF, plus the subarachnoid space fluid, the CSF, then we call this meningitis. Then we call it meningitis. But when there is direct inflammation, direct insult to the brain, this parenchyma is involved, direct, most commonly by viral, then we call it encephalitis. When there is injury or direct insult, direct trauma to this by a virus, we call encephalitis. Though there is bacterial and fungal causes also there, but viral encephalitis is very common. Okay, and when there is a inflammation of the covering of the brain, pia mater and arachnoid mater, then we call it meningitis plus inflammation of the also CSF. And sometimes when there is meningitis, it also involves the parenchyma of the, it also involves the brain, then we call this meningoencephalitis, because both the things are present, right? So that is how we will differentiate in meningitis and encephalitis. Okay, and in meningitis we will see a direct accumulation of pus around this, in the direct accumulation of pus in the leptomeningeal layer. There will be formation of exudates. Alright, so this is the basic difference between meningitis and encephalitis. And another thing is that you have to know a little bit more anatomy about what is the importance of this leptomeninges. This leptomeninges is also, it is involved in production of a important enzyme called PGD2 synthase. It comes as a MCQ sometimes in entrance exam, PGD2 synthase. This leptomeninges is important contributor of this enzyme called prostaglandins D2 synthase. So this PGD2 synthase, it helps in conversion of prostaglandin H2. So it mediates this reaction H2 to D2. So this prostaglandin D2, which is finally formed, what does it do? It is an important modulator in smooth muscle contraction and relaxation, also a neuromodulator, and it is an important protein found in CSF. Though CSF protein is very less, but it is found in CSF. Okay, so that is the importance of leptomeninges. Okay, now let's go ahead for meningitis. Okay, first we'll go to the causes. Okay, what are the causes? So when you say the causes of meningitis, we'll go in a different cycle, because everybody knows, okay, that bacteria are more common. So that's why we'll discuss in form of bacterial meningitis, right? Alright, so 5 things you need to know, which are the common bacteria involved in meningitis. The 5 things, that one is Streptococcus pneumonia, streptonemonia. Second is Listeria meningitis. Okay. Third is group B, Streptococcus, which is also called Streptococcus agalactia. And fourth is what you call Haemophilus influenza. And another is what you call as Listeria Monocytogenes. So these are, and plus don't forget E. coli. So these are the few bacteria which are common in causing bacterial meningitis, but they all differ in age groups. So we'll study the cause of the meningitis according to the age group. Meningitis according to the age group. So when you say premature babies, or you can say neonates, less than 3 months old, okay. In case of premature babies and neonates which are less than 3 months old, the most common cause of meningitis is group B streptococcus. So here it's coming as, here's group B streptococcus, or you can say Streptococcus agalexia. Now why it is common? Because group B streptococcus or Streptococcus agalexia is present, normally it's present in the vagina. So when there is a vaginal delivery, so it is very likely that they can get this contamination. Plus here E. coli, which is present in the digestive system. Plus there is Listeria monocytogenes. So Listeria monocytogenes, which usually it infects the pregnant mother, and this bacteria is usually present in contaminated food like uncooked meat and hot dogs, then all those barbecue things, and in dairy products like cheese. In those, Listeria monocytogenes are present. So when a pregnant lady eats those contaminated food, then it can go to her digestive system and can infect the neonate or her baby. So this is the commonest. So when a question comes, what is the commonest cause for 3-month or 2-month-old baby? Then it is the group B streptococcus or Streptococcus agalexia. Then we go to this is the number 1. Then we go to the different age category. This is older children. In older children, okay, number 2. So in older children, it coming with the now commonest cause of Neisseria group, Neisseria meningitidis and Streptococcus pneumonia. Now both this Neisseria meningitidis and Streptococcus pneumonia, they are now, as the age progresses, they are going for the most common causes. Okay. Then from older children, we go to the adults. In adults, 80% of cases are all done by Neisseria meningitidis and Streptococcus pneumonia in 80% of it. Okay. Here in older children also Haemophilus influenza I missed out. Okay. Now as it goes from adults to older people, then in older people, that is around more than 50 years of age, it's Listeria monocytogenes, it dominates. So you can see Listeria monocytogenes in 2 extremes. It is also found here in the babies in less than 3 months and also found in more than 50 years. Plus also Streptococcus and Neisseria meningitidis, both the things. Okay. So, but because of vaccination available, the meningococcal meningitis, or which you call Neisseria meningitidis, it has gone quite down. But the main thing is that the vaccination is available only. So the vaccination that is available for Neisseria meningitidis is not for the type B. Okay. So Neisseria meningitidis have different classes. It has different classes like vaccination is available for A, okay, and C, and IV 135. All these are classes. So vaccination is available only for this, not for serogroup B kind of thing. Okay, so whatever the vaccination is available in the commercial market, it is not against group B, serogroup B. So all the causes of meningococcal meningitis caused by Neisseria meningitidis is caused by serogroup B, not by this thing, because this we already got the vaccination. Okay, So that is the difference. So, but still, because of plenty vaccinations for pneumococcal and meningococcal, nowadays cases are going down by this group of bacteria. Okay, so these are the basic causes of meningitis, causes of bacterial meningitis. Now we go to the pathophysiology. To understand the pathophysiology, you must know that there are few things to be understood here. That all these bacteria we have discussed, except Listeria monocytogenes, because it has not been researched we don't know much about Listeria monocytogenes, but all these bacteria, they have one common thing, that is polysaccharide capsule. They have a polysaccharide capsule. Though this polysaccharide capsule is most dominantly it is found in gram-negative bacteria, okay, but it's also found in gram-positive bacteria like Streptococcus pneumoniae. It is found in all this causative bacteria causing meningitis. This is polysaccharide capsule, which is the outermost capsule of a bacteria. Okay, so they have this thing common. Okay, now let's try to understand the pathophysiology. So when we say pathophysiology, so why this Streptococcus pneumonia and Haemophilus influenza bacteria and Neisseria meningitis, what are the things? Another common thing, that they are normally invading our nasal mucosa. Normally they are present in nasal mucosa. They are normally found in nasal mucosa. Okay, they often inhibit the nasal mucosa. That's why any patient who has a background of otitis media or rhinitis, sinusitis, they are always in a risk factor for developing meningitis. Okay, so now the thing is that they are present in the nasal mucosa. Okay, let's say they are colonizing the nasal mucosa. Now the first thing is the transportation. So first thing you write, when you write the pathophysiology, you write number 1 is transportation. Transportation. So they normally colonize here in our nasal mucosa, in our nasopharynx, and from here they will transportation by vacuoles, by migration by vacuole. Okay, they are migrating by vacuoles. So once they migrate, so these vacuoles, they encapsulate these things, encapsulates, and they carry into our bloodstream. They carry into the bloodstream. They carry into the bloodstream. So first is transportation. Next, once they are into the blood, once these bacteria are into the blood, they cannot be easily phagocytosed because of presence of, as I discussed, because of presence of phagocytosis. So after transportation, they escape the phagocytosis or neutralization by our complement, escape by our complement system and neutrophils. How? Because of presence of polysaccharide capsules. Because of presence of polysaccharide capsules, they escape the phagocytosis. Now they are transporting in the blood. Now they are finding a route, they are finding a way to escape into the CSF. So that escaping into the CSF is possible only when they attack the most vulnerable part, where the blood-brain barrier is not so fully evident, or blood-brain barrier is vulnerable. Which is that place? That place is choroid plexus. So now they go to attack the choroid plexus. So I'm not going to the details of anatomy of the choroid plexus, but you have to know a little bit about choroid plexus. That you can see this is the blood vessel, and there is a portion of in the brain. You can say there are 4 ventricles in the brain. There are 4 ventricles. Okay, there are 2 lateral ventricles. 2 lateral ventricles, then there is a 3rd ventricle, then there is a 4th ventricle. Okay, 4th ventricle, 3rd ventricle, just a rough diagram, 3rd ventricle, and there are 2 lateral ventricles. So when the blood flow, so there is a portion in the blood vessels, when they go close to the ventricles, there is a kind of shower. There is a perforation here. You can imagine there is this kind of shower. So here the blood-brain barrier is not so developed, or you can say because of this penetration. Okay, so here suddenly the blood vessels, they are becoming a villi. Okay, because of there is some specialized ependymal cells. There are some specialized ependymal cells develops here close to the ventricles. Okay, and they are called as choroid plexus. So when the blood is going this way, then there is special filtrate, clear filtrate like plasma, it escapes through these pores. Okay, where are these pores present? These pores are present in the choroid plexus. These choroid plexus are present in both the lateral ventricles, in the third ventricle also, in the fourth ventricle also. So from here, what happens? This clear plasma escapes from the blood, which is colorless. We call it CSF. So ultimately, CSF is a ultra filtrate of blood. Okay. So CSF comes from both the ventricles, goes to the third ventricle through the interventricular foramen. From the third ventricle goes to the fourth ventricle through the cerebral aqueduct, and from the fourth ventricle it exits to the central canal and the foramens. Okay, it exits, and where it goes, it exits, and it makes a round here. It goes to the subarachnoid space and to the spinal cord, in the central canal of spinal cord. Okay, we know that CSF is normally formed at a, anytime you'll find CSF you'll find at a 150 ml per day you'll find, but every day there is 500 ml is formed. Okay, normal volume of CSF 150 ml. Okay, so if there is an entry, so CSF is rotating here, is circulating here, so there must be an exit point. So where does it exit point? Because of some, yes, some. So from this, there are some exit points. These are called arachnoid granulations. These are called arachnoid granulations. So through the arachnoid granulation, this CSF escapes to the superior sagittal sinus. Superior sagittal sinus. So CSF, it comes from here and it goes and through the spinal cord it rotates and it escapes through the arachnoid granulations. So there is continuous entry and exit, and it maintains the 150 ml, and it's clear colorless fluid which is less than 5 WBCs anytime per deciliter. 5 WBCs, less protein, less glucose. Okay, and it is not so crowded. You can see there's less than 5 WBCs per cubic millimeter blood, per cubic millimeter, less than 5 WBCs. So it's not so crowded. Because it's not so crowded, that's why CSF is transparent. It is clear, it is colorless. Once it is crowded, it will become turbid. Okay, so it has got minimum things, less immunogenic things, less proteins, less. So it is made. So that's why the CSF is made colorless and transparent. So we will not discuss much about the functions of CSF. We know the functions of CSF. Okay, so we are going to the pathophysiology of meningitis again. So first there is a transportation from the mucosa to the blood. Okay, so first there is transportation of bacteria from mucosa, nasal mucosa to the blood. Then escaping by our complement system because of presence of polysaccharide capsule. Then third is attacking the choroid plexus. Here they penetrate here. They penetrate here. Now what happens? Now the bacteria is present here in our CSF. Now this whole CSF is present with her. It does toxic bacteria, with the bacteria. Now still the meningitis has not yet started. Meningitis will start now. Now the next thing to be noted in pathophysiology, the first thing there is a liquid nature. That's why phagocytosis is not possible. Phagocytosis is very, very poor because the bacteria, they are swimming in the CSF. Okay, because of the liquid nature, it is poor. Second thing, there is less than 5 WBCs per cubic millimeter. So it's not possible to phagocyte all the bacteria, but there will be some phagocytosis. Okay, because still we have got some WBCs. So now the first sign of meningitis will start from here, when there will be phagocytosis of, or there will be killing of, you can say there will be killing of few WBC, few bacteria. So what happens if there is a killing of few bacteria? So number 4, when one bacteria die, there is a release of bacterial cell membrane. Bacterial cell membrane. Now what this bacterial cell membrane contains? This bacterial cell membrane contains peptidoglycan, teichoic acid. They also contains lipopolysaccharide. So they contains this. So when a bacteria dies, they release this peptidoglycan, they release the teichoic acid, they release lipopolysaccharide molecules. So these peptidoglycans, teichoic acid and lipopolysaccharide, they will ignite our immune system. So meningitis is not actually only because of the bacterial invasion. It is 80%. It is because of our immune aggression of our, or the ignition of our immune system. You can say there is collateral damage now onwards. So now there is, when the bacteria dies, then they release the cell membrane product like peptidoglycan, teichoic acid and lipopolysaccharides. Now as a result, they will stimulate the cytokines. They will stimulate the cytokines and they will stimulate release of cytokines and chemokines. They will stimulate release of cytokines and chemokines. By whom? By our immune cells present in our central nervous system, like microglia. Okay, like Microglia Astrocytes. These are immune cells present in our central nervous system. Okay, so Microglia Astrocytes, so they will continuously release these cytokines and chemokines. Plus there will be release of TNF, tumor necrosis factor alpha. Plus there is release of interleukins 1 beta. They will release, all these are immune products. All these are immunostimulants. All these are, they are releasing their immune mediator. They are releasing plenty and plenty of cytokines and chemokines. So the meningitis will start from here actually. So once the cytokines and chemokines are released, what will happen? Okay. So once the cytokines and chemokines are released, now they will do first thing. They will increase the permeability of here. Increase the permeability of blood-brain barrier. First thing, by metalloproteinase enzyme, MMP, metallic metalloproteinase enzyme, and release of nitric oxide and reactive oxygens. Nitric oxide and reactive oxygens. Okay, so they will increase. So as a result, you can see there is permeability is increased. Now lots and lots of CSF is coming. Lots and lots of fluid is coming. So when you increase the permeability, what will happen? Suddenly CSF volume, which is normally 150 ml, it can go up to 300, it can go up to 500. The volume has increased. So volume has increased. It means increased intracranial pressure is happening here. Now you have increased the permeability. So lots and lots of proteins and WBCs are escaping. Proteins and WBCs are escaping here. So CSF proteins is increased. Normally we can say 15 to 45 milligram CSF protein, but now it has increased. So protein has increased WBCs. So do you think the CSF will still be look transparent? No. Because of its cloudiness, because of a huge crowd inside, bacteria are inside, bacterial exudates are inside, protein, heavy protein is inside now, WBCs are inside, because everything is now leaking here. So CSF will not be transparent anymore. CSF will become turbid. That is one thing. So increase permeability. Then what else they do? they also affect our hypothalamic temperature control center, causing fever. Plus, the meninges is involved here. The meninges are involved. We are saying that now when the CSF is involved, because now this volume is increased, right? So volume is increased. So CSF volume is increased. Suddenly from 150 ml it has gone to 400 ml or 500 ml. It has increased. So there is a stretching of the brain. So meninges, the whole meninges is stretching. Now if the meninges covering this brain is stretched, so can we fold our neck? So when we fold our, when we do the flexion of neck, we are stretching our meninges. So every time we fold our neck, we are stretching our meninges. So when the meninges is inflamed, it's becoming rigid because of the increased volume. There will be difficulty in passive flexion of the neck, what we call as neck rigidity. So fever and there will be neck rigidity because of meningeal inflammation. Okay, but because every time we flex our neck, meninges are stretched. So because of meningeal inflammation, there will be neck rigidity. So neck rigidity, high fever, okay, and headache, and all these CSF signs, they are pathognomic signs of meningitis. In meningitis, this thing will happen, and this thing must happen because of this, all our over expression of our immune system. Okay. Next, what happens? So, other than that, this turbidity, and now you can see, you can see here. So suddenly there will be increased CSF in these ventricles, right? So increased CSF. So there will be CSF, increased CSF, right? So there will be, you can say there is, it is always possible of hydrocephalus, increased volume of CSF. Now if you put a lumbar puncture needle somewhere here, lumbar puncture needle, in a high pressure CSF is there, so CSF, the opening tap pressure will be very, very high. So when you put a lumbar puncture, the CSF that will come out will be high opening tap pressure. Okay, so that is also found in meningitis. Along with this, there can be always cerebral herniation. There can be always cerebral herniation. Cerebral herniation because of increased intracranial pressure. There will be cerebral herniation. The cerebrum might come out towards the downward side, towards the foramen magnum side. It might herniate this side. It might try to herniate. Now there is increased intracranial pressure here. So CSF is, everything is stretched. So that increased intracranial pressure will surely, it will try to close because of the herniation, because of the hydrocephalus, it will try to close the blood vessels. The blood vessels found in the brain, they are in a limited space. So it will get an extra pressure, narrowing of the blood vessels, which can cause anoxia, which can cause loss of consciousness, which can cause seizures or epilepsy or some focal neurological deficits. 6th nerve palsy is very, very common in these cases because it is very, very prominent. Plus, because of this stretching, there will be headache. So headache, fever, neck rigidity, and all those cardiac signs, Brudzinski signs, okay, and meningeal inflammation. These are the basic things that are found in meningitis. And what else in here is that, okay, one more thing that you have to note here. So in meningitis, in case of CSF, the glucose component, CSF glucose, which is normally more than 2/3 of blood glucose. Normally more than 2/3. Now let's say normal blood glucose is 110 milligram per deciliter. So normal CSF sugar should be around 2/3. 2/3 is, it will be around 80. So it will be around more than 80. Suppose it can be around 80 to 90 milligram per deciliter. But in CSF, in meningitis, the CSF glucose is significantly reduced. There will be a lot of talks about why CSF glucose is reduced. So it is multifactorial. Number one is that glucose is used here. You can say it is used by the immune cells. All those immune cells that leak here. It is used by the bacteria for the energy. Plus, main thing that why CSF glucose is suddenly decreased is that CSF glucose could not be transported. Because where the CSF glucose comes, it comes from the blood. Now, when the meningitis develops significantly, there is clogging of these things. And glucose cannot be transported anymore from the blood to the CSF. That's why CSF glucose significantly reduced. Okay? So, see, decrease of CSF glucose, it has got multi-cause. Okay, number one, consumption by bacteria and immune cells. Number two, CSF glucose transportation is significantly affected in meningitis. Okay? Third thing, this arachnoid granulations here, it can be also blocked, and sometimes the whole entry and exit is blocked, and there is a local herniation, cerebral edema, and neurological deficit. Plus, what else? The release of nitric oxide and reactive oxygen species by our cytokines, by our immune cells. Okay, they can cause brain cell damage, brain cell death. They can cause the death of our brain cells because of the release of this nitric oxide species, nitrogen species, reactive oxygen species. All this can do significant brain cell damage, and it can cause to death. So this is the basic pathophysiology of meningitis in very, very short. Okay, thank you very much.